of these speakers with multiple credentials, so bear with me so I don't discredit his past research and educational experience. Dr. Michael Wargovich is a professor of molecular medicine here at the Health Science Center and the CTRC Council Distinguished Chair in Oncology, UT Regents Health Research Scholar. He came to us in 2012 from South Carolina, where he was the Director of Basic Science Research at South Carolina Cancer Center, the University of South Carolina. There he was responsible for the cancer research facility encompassing 5 multidisciplinary cancer researchers at Palmetto Health Hospital. He has an NCI funding for biomarker reference laboratory for the prevention trials conducted by the NCI. He got his PhD at Texas Tech and has had multiple postdoctoral fellowships in biomedical sciences, cancer prevention research. Again, presently he's the program co-director at the Cancer Therapy Research Center here, and today I'll let him provide some additional highlights in his career and his present pathways. But today he's going to talk to us on the role of anti-inflammatory diet post-transplant. You don't want this. I will set this up. Again, I got a pointer, and
okay,
advance them back, and they'll take care of lights.
Okay, good morning. Yeah, that was a little butchered. I actually moved here from Charleston, South Carolina, which will become relevant just at the start. I have to say I'm going to mention for about 2 slides a startup company I brought here called Can Survive Cuisine, which will be important for this presentation. So thank you for the invitation. I've been here about 3 years. I head the cancer prevention program for the CTRC. And you're probably looking at the title and saying, what the hell is he going to talk about? You know, so actually there's a lot of great science that's going on in this, and I'd just like to begin that you're going to hear today the first results of a clinical trial in breast cancer survivors using anti-inflammatory intervention, and why we chose a dietary culinary approach rather than drugs. Study is funded by the Komen Foundation for the Cure. My co-PI is Amelie Ramirez. Okay, so you all know that organ transplant is just half the battle. People wait so long for organ transplants, and you're doing a really good job in terms of the survival. 5 years looking pretty good for renal and liver transplant, and less for lung. But then we have to look at the other side. So Jennifer Milton is one of the people who I've been talking with, and we got to talking, and I learned a little bit about what happens after transplant. And so for renal transplant, there's a pretty good risk of developing hypertension, heart failure, and arrhythmias. And a lot of the transplant patients, if they weren't obese, become obese. And a lot of them become diabetic. That may or may not be associated with the transplant procedure, or just with lifestyle thereafter, with a little bit of complications. For liver, hypertension, of course, is one of the risk factors, and obesity, as well as inflammatory bowel disease in the transplant patient is 10-fold higher in terms of risk than the non-transplant patients. So, I mean, on my thinking, you do a wonderful, heroic job, and then on the other side, the body contributes to some long-term consequences. So I'm a cancer researcher, and we have to admit that organ transplant actually does bring a future risk for cancer. So overall, 2 to 4-fold greater for the transplant patient for risk of cancer. Probably the most common is non-Hodgkin's lymphoma. But then you could probably figure out that wherever you do the transplants are probably a site of cancer. So lung, liver, and kidney cancer, especially in the younger transplant patients, is a possibility down the road. So the question is, what can we do about that? And the answer seems to be inflammation. Now, I work in an inflammation laboratory, and when I talk about inflammation, we have to really explained that this is the chronically and clinically invisible unresolved inflammation that might create a very high risk for cancer. So clinically invisible, we can't test that. You as practicing physicians and caregivers, we don't have really good measures of chronic inflammation throughout the body. We have some that we're thinking about and some that we're using. I'll show you those in a little bit. What we learned about this natural healing process is that human cancers corrupt the inflammatory pathway in order to survive and metastasize. So to put it simply, they hijack the immune system to give them a growth advantage. And drivers of chronic inflammatory disease are suspected to be markers that we can measure in the blood, including elevated CRP. I'm going to talk a little bit about that, and the interleukins 1-6, 2-15, and TNF-alpha. And that's not important right now. I'll explain them in a little bit, but just bear those in mind. So the difference between acute inflammation, we have injury. Injury might be due to infarction. It might be due to exposure to toxins, to the trauma of surgery itself. And acute inflammation comes and goes. So you have a healing process that is going to lead to resolution of the lesion, of the damage to the body, clearance of the injurious stimuli. I mean, that's the first reason inflammation occurs, especially if it's a type of infection. And your replacement of injured cells and hopefully normal function. And I know as transplanters you all hope for that. But acute inflammation can be corrupted. And in the context of long-standing type of injury, viral infections, chronic infections, persistent injury, or maybe even autoimmune disease, the acute inflammation morphs into chronic, and chronic involves angiogenesis, fibrosis, and scarring, and that's probably the best you can hope for. At the nuclear level and the cell level, it persists, and those pathways are used diabolically by human tumors in order to survive and metastasize. So you'll see this all over the internet if you kind of look at this particular chart here, something that we couldn't even consider 10 to 15 years ago, that chronic inflammation is now considered to be Grand Central Station at the heart of all of these diseases that are linked through the same types of pathways that lead to the corruption of chronic inflammation. So obviously we learned about that first in heart disease, but now we're certain in cancer. And categorically now, obesity and diabetes, asthma and Alzheimer's are classified as chronic inflammatory diseases. Of course, you probably realize in dealing with tissue damage, anytime you have the short term of itis damage in any organ, if that persists over time, it will become a stimulus for cancer. So thought that these things were kind of independent 15 years ago. We now believe that they're all linked through common mechanisms. That gives us the opportunity to intervene. So let me just jump up to the world view and explain a little bit of what's going on. As a cancer researcher, we're really concerned. When I was a student up at Texas Tech, they kind of burned this into our brains that cancer is a fundamental property of being from Western Europe, and the countries that show high risk for cancers tend to be ones that are populated from migrations from Western Europe. So you have the genetic heritage on top of the environmental and cultural heritage, and one of the absolutes at that time was that it's not always a function of being in the developing world, and that the underdeveloped world actually had no risk for cancer. So it had to be part of our lifestyle, part of being industrial, part of being polluted, part of being densely packed. Well, everything has changed, and this is what scares us, in that in the next 10 to 20 years, all the risks for the major cancers in the world are going to slip into the developing world. So pretty much south of the equator, Mexico is going to become a huge hotspot for cancer, as of all of South America, a lot of parts of northern Africa, the Middle East, Southeast Asia. These are countries that have never historically experienced breast cancer, colon, prostate, or lung cancer, as they will. What's happening? So epidemiologists have given us some hints. It's called acculturation. So everybody in the developing world wants to watch YouTube and become a middle-class American, eat like a middle-class American, and course, they're getting the chronic inflammatory diseases of middle-class America. That train's left the station. It's really hard for us to even think about pulling it back. The cancer research world talks about cancer tsunamis coming, and you're going to see it more in the news. You're going to see it on CNN over the next 10 or 15 years. Everybody's going to say, what the hell's happening? And what has happened, we think, in part, is that a lot of the cultural things that people did in the low-risk countries have gone by the boards. They pretty much reformed their diet, and it turned out that elements of their diet were the protective factors. And it turned out to be the anti-inflammatories that I'm going to talk about. It makes a lot of sense, and we'll see where we go with this. So is there a relationship between chronic inflammation and cancer risk? We know that acute inflammations increase risk in certain organs. So we're not exactly brain surgeons in cancer research. The way we came about understanding this is we found out that people who take anti-inflammatory drugs and have done that for 10 to 15 years have a much lower risk for cancer than the general public. So long-term NSAID use protects against many common cancers. How much? Your risk drops by 50%. And for us in Texas, in South Texas, which has one of the highest risks in the North America for liver cancer, 17-fold if you're male, if you're over 50, if you're Hispanic. Obesity and diabetes raise the risk for certain cancers. We're certain that this is tied to lifestyle and the changes that have happened just in the last 10 to 15 years. Okay, so I'm building a case for this marker called CRP because I'm going to reveal some of the first results of our clinical trial that we conducted in breast cancer survivors. So CRP is the marker of the day. So if you haven't had yours drawn for a while and talked to your cardiologist or general practitioner, this marker looks very impressive for predicting who might be at risk for heart attacks and now for cancer. So basically, I'm not going to go through all this, but some of the mediators are the ones I mentioned, interleukin-6 and TNF-alpha, and it's a little bit of a dance and a circular dance in that all these factors raise CRP. That you can't read that in the back, but includes your genes, your environments, your socioeconomic status, your lifestyle, obesity, insulin resistance, resistance to statins, all those can raise CRP. Basically, it's a 1, 2, 3 scale. If you got your CRP measured, if you're down 1 milligram per liter, then you're at pretty low risk for chronic diseases. 2, you're at average risk. 3.0 and higher, you are at much higher risk for what I'm going to talk about in the next couple of slides. So when we were designing this trial in breast cancer survivors, CRP looked kind of iffy out there. The cardiologist told us that's the one they're going to measure because their field's moving away from measuring lipids and cholesterol as risk factors, and they embrace CRP. But the first papers started to come out across the board in important tumors saying that elevated CRP was associated with cancer risk. So if you're 3 or above, then your risk for the risk for colorectal cancer is almost twice what it would be if you have a low CRP. For lung cancer, it's 3-fold. In melanoma, which is something we wouldn't actually consider, but now much more important disease, especially in the Sunbelt states, a high CRP indicates, if you've had melanoma, a greater chance for recurrence, a greater chance of dying. And that's up to 44 to 59%. Breast cancer was one that we were interested in because we were going to conduct a breast cancer trial. So if you have an elevated CRP, your risk of dying from all causes is up by 96%. Your chances of dying from a recurrent breast cancer is 91%. Well, dying from factors associated with breast cancer is 91%, and the chances of recurrence are 69% higher than having a low CRP. So a meta-analysis in 11 different studies now reveals that elevated CRP increases risk for all of these important cancers. So that's so what's driving CRP, and what can you do to modify it? So just to show you the risk in breast cancer, when we actually applied for this study, we didn't have this data, but it looks pretty impressive now that continually high CRP is going to confer extraordinary risk for reappearance of this disease or doing poorly after breast cancer surgery or treatment. So C-reactive protein, that's what it's called, synthesized by the liver, released by macrophages and fat cells. Interleukin-6 is the driver of this, and that's an important blood marker in people to look at to say whether they're chronically inflamed or not. So that was the marker we chose for our clinical trial. So you immediately go back to my thought about anti-inflammatory drugs. Should everybody be taking NSAIDs? So working with the National Cancer Institute for many years, there were actually proponents that said, yeah, this should be in the drinking water. I mean, it's that powerful. So there are strong animal and human medication evidence of a protective effect against many cancers. The kicker is that you have to be taking at least a baby aspirin to a full aspirin a day for 5 years. And the effect really comes in the benefit after 10 years. Now, physicians in the room, you probably have gotten a message from the U.S. Preventative Health Task Force recommending that all physicians talk to all patients now about aspirin therapy. If you're 50 years or older, you should be talking to your patients about using low-dose aspirin for men starting at 50, for women starting at 60. As a preventative for heart attack, they're absolutely sure of that. We've known that for some time. But now the new recommendation talks about prevention of colorectal cancer. And my lab has actually been part of that story for 20 years. But at the same time, we know that not all NSAIDs are safe. In fact, most of them are not. And one of the things that's out there still is called Celebrex, and used for a lot of arthritic conditions, and you know the story of that, and the Merck compound Vioxx that showed that clinical trials found that use of Celebrex and even in post-marketing follow-up found that patients are at risk for heart attack. So what's going on? You're suppressing inflammation, which is great, and you're causing heart attacks, which is not. So I'm not going to go into that biochemical slide of all the prostanoids, but basically everything's a balance in biology. If you suppress one side, you can expect compensation on the other side. Why that didn't enter into the brains of people when they started putting these drugs in the people, I don't know. But the truth is that if you take these non-steroidal anti-inflammatory drugs, the COX-2 inhibitors, which are allegedly safe from the side effects of all the other NSAIDs, you actually cause thrombogenesis in a lot of people and risk for heart attack. So on the one hand, they're telling physicians and caregivers, talk to your patients about aspirin, low-dose aspirin, every day. And on the other hand, in July, the FDA decided to strengthen quite dramatically all of the box warnings on every pain reliever out there, including the over-the-counter drugs, ibuprofen, naproxen, and other drugs. So there you are on one hand. You're telling your patients the anti-inflammatory drugs are good, but you can't use any of the others. So what can we do about that if we want to move forward? Well, it's a medical decision. I've been on aspirin for 13 years. I haven't had a problem, but a lot of people do the math that you say it's one aspirin, they're going to go over to Walgreens and take 8 a day, right? So they're going to end up in the ER with bleeding and kidney dysfunction. So NSAIDs are not the answer, but let me just show you some of the data. This is from colorectal cancer. So if you have a polyp, you go to your GI doc and have a polyp removed, there's a chance that you'll have a recurrence in the next 3 years. So you go back to see your doc in 3 years. If you're an aspirin user, your chances of developing a new polyp are 50% less. If you use any other drug other than aspirin every day, your chance of developing a polyp is 50% less. Cancer incidence across the board, you know these epidemiological slides now, if the bars are to the left, highly protective, so across all cancers, 50% less. And most importantly, dying from cancer, 50% less. So we're in a rock and a hard place, right? So we have the drugs. We know that they might prevent cancer. We know that they might prevent future risk of cancer, but they're unsafe for the general population. In the context of a medical clinic, I think they would probably be the route of choice, but let's just think about the general public and what we can do about that. So let's turn to supplements. Are there anti-inflammatory supplements? Of course they are. If you've been following the cardiovascular literature, it's fish oil supplements. randomized double-blinded controlled trials of fish oil ingestion about 1 gram a day for 6 months to a year. Actually drives down CRP in the blood pretty well. But that's hard for people to maintain. If you ever been or talked to people that were involved in the initial cardiovascular heart attack prevention trials in which they were given a supplement or fish oil capsule, the people in the fish oil capsules knew that right away, pretty quickly after ingestion, because they burp and they smell like fish. But so amenable for everybody? No. Okay, for people who truly have religion, maybe, but that's one possibility. So let me talk about what I really came to talk about with all that background and the results of a first of its kind clinical trial here at the Health Science Center. I really want you to think about this in the context of your transplant patients. So the study was called Prescription for Better Breast Health. It was a tailored culinary-based intervention to alter the dietary patterns of breast cancer survivors in attempts to inhibit their chances for recurrence. It's a 1-year study. Of course, we're not going to have recurrence. So we use these intermediate markers. Could we drive down whole body inflammation with just a culinary approach? And you might think, so what's important about the culinary? And you'll see that in a minute. So the goal was to alter the dietary profile of targeting foods with anti-inflammatory properties. And guess what, folks? Everything that the people, our planet is giving up as they move to the fast food diet were the anti-inflammatories. They're in the herbs and spices, in almost at the level of biomedicinals. So we had a couple of goals in this study. First of all, we were going to see whether we could decrease circulating adipose cells. The adipose stromal cells are the supportive fat cells around the breast. They do get into the bloodstream, and that seems to be a marker now of who might progress in cancer. Difficult assay to do, and no one's really shown that you can modify that in an obese cancer patient. The other markers I've already introduced, the major things that influence CRP, as well as the individual interleukins and tumor necrosis factor. So those are sort of the goals of the trial. So the rationale for the culinary intervention, and this is where you think this might get into pseudoscience, but there's been 20 years of hard research on this. So this is your prescription for going home. This is just a handful of what our patients were introduced to. Basically, if you're in the kitchen at home, if it's colored, if it smells good, if it tastes different, those are the biomedicinals, and most of them have anti-inflammatory activity. Just think about other parts of the world where these are essential parts of the culture. Just let me give you, for instance, what's going on in the world. I'm a colorectal cancer researcher. Anybody want to take a guess where, just pick a major city in the world that has the highest risk for colorectal cancer today? Take a wild guess. Minnesota. Minneapolis. No, it's actually Shanghai, China, followed by Singapore, followed by Hong Kong, followed by Tokyo. So all Asian countries who have embraced Westernization and have never seen in the last 30 years the risk for colorectal cancer that they're experiencing now. So in the developing world, these are the things that go bye-bye when they acculturate. And that includes turmeric, cloves, curcumin, cardamom, cloves, black pepper. I could talk a long time about how these things work. So there's a long list of things to choose from. Are these just guesses from a chef? No, they're actually well validated. So the validation process for anti-inflammatory foods involved a scientific review of PubMed literature from 1980 to present, guided by acculturative changes in the population. So what are people no longer putting into the way they cook at home? Those probably were the protective elements. And so to be validated, there had to be at least 5 published reports showing in vitro activity and at least 1 report in animal models, or at least 1 clinical study in which human subjects were given the spice as a supplement or what have you, and produced evidence of an anti-inflammatory response. Okay, I'm not going to list all these things, but just to show you some things that have become interesting to Americans, but not to the level in which we should be exposed to these things. Green tea is one of the most validated anti-inflammatories out there. There's strong evidence from epidemiologic studies, powerful evidence from animal studies, and this is the kicker again about the green tea studies. In the cup of tea that you might be drinking this morning, the concentration in that cup of tea is what has shown promise in animal studies. So this isn't a truckload or swimming pool full of green tea. This is what we're exposed to on a daily basis. So most studies have focused on something you might see over in Walgreens. They'll hype the agent called EGCG, that is the powerful antioxidant in green tea. It has anti-inflammatory and epigenetic activity, safe in gram quantities. There have been patient studies with this. Most importantly, if you remember back to the drivers of chronic inflammation, this suppresses in the body all these interleukins and especially TNF-alpha. So great, start drinking green tea. Well, no, it's not the answer. It's tough for Americans to think about this. And so I have a sister-in-law who pulls into Starbucks and gets that huge thing of green tea every day. So before she pulls out, she asks for 5 shots of sugar in it, sugar syrup. Okay, so you're taking the anti-inflammatory and destroying the benefit. Another lecture for another time is sugar is now considered to be a preferential fuel for human cancers, and it links directly into chronic inflammation. So one of our jobs was, how do we get green tea into cancer patients who have survived and want to make changes? Just to illustrate another thing that's very, very promising is this Asian spice called turmeric. I don't know if you've actually seen the root. You can probably find this over in Central Market, and it looks just like it does in the picture. It's one of the most investigated anti-cancer spices at the National Cancer Institute. You'll hear that the responsible agent is called curcumin. You can buy curcumin supplements, okay? So if you want to go that route, there's a danger sign going up. So if you haven't heard this, here's a shocker. If you've been taking multivitamin supplements for 10 or 15 years for better health, the latest results from Harvard indicate that you're going to shorten your life by 7 to 8 years if you take a multivitamin every day. And so what the hell, right? So, and we can talk about that, and everything is a switch, right? If you put too many oxidants in the body, you can become pro-oxidative and cause trouble. Anyhow, this spice, turmeric, is potently anti-inflammatory, safe in gram quantities, and hits those same interleukins. Okay, so if we're talking about our patients, and I'm going to end up talking about your patients, and the study that I'm about to reveal the results on, this was not a diet. We didn't sell this as a diet to our patients, because the first thing they're going to say is, Doc, I've been on a diet, you're going to take away what I like, bye-bye. So we just gave them background to say, follow a Mediterranean-style diet, which is kind of up on the screen, encouraging fruits and vegetables. We had to teach them what marine fish were. This isn't tilapia or catfish. And they said, well, it's too expensive. I'm not going to go out and buy salmon. But, tinned salmon, canned tuna, sardines are all got the omega-3s that are anti-inflammatory. And we educate them on culinary oils. For example, there should be only 2 oils you use at home, olive and canola. Everything else feeds inflammation. That includes peanut, corn oil, safflower, so canola and olive. And it was a hard education process, and I'm going to talk about how we went about doing that. So this is the disclosure. I have a startup company that I'm involved with, and the star of this is Chef Iverson Burnell. He was part and parcel of the intervention for the trial that we did in women. He is one of the executive chefs down at the St. Anthony Hotel. So a commercial there, when they open up and you want to get anti-inflammatory food, head to the St. Anthony. So the design of the trial was a 2x3 randomized controlled trial. We had group assignments of studies versus control. We brought the women into the study. There were 150 recruited, and we split those by randomization into 2 arms. We took blood samples at baseline at the end of 6 months, in which half of the women got a full power intervention. And the study is still ongoing. So we're now in the second 6 months, where both arms are treated equally. The difference between the arms during the intervention, you're going to see in a second, but basically now everybody's just getting information that you might get from pamphlets, from literature, from newsletters. but no coaching on how to do the intervention. So the inclusion criteria, we took women who were 18 or older. They had to have a primary diagnosis of breast cancer stage 0 to 3, and no evidence of metastatic disease, fluent in English, and these were overweight to obese women. We actually started the study with a BMI of 30 and dropped it to 25. So we had, relatively overweight women. The CRP should be elevated in all those women, and their risk for recurrence much higher than a woman who is lean. So we started by screening over 300 patients. Some of them went by the boards for many reasons. We randomized 153 into the 2 arms. And the 6-month on intervention, which was either active intervention or educational. And sort of where we are is about right here. We just finished the 6-month analysis, and women are on cruise control for the last 6 months. Of course, we don't know what to expect in terms of the blood markers. I will show the results today. And we expect that there will probably be regression back to the baseline over the second 6 months. So the intervention was based on a culinary workshop. This was a lot of work. Held once a month for 6 months. Because we could only bring 20 to 25 patients in at a time, we had to do rolling workshops. We had to do those either in the morning for people who couldn't come in the evening. People who worked during the day had to come to an evening one. It was exhausting. We had about a 70% consistent attendance. It involved myself, a project coordinator, and Chef Brownell. The design of the intervention was a 15-minute PowerPoint like this, done in a very conversational tone, in which we educated the women on the hows and whys. We actually put some pretty good biology and medicine in there, and followed by an active cooking demonstration, a tasting afterward, and then bombarding them with recipes. So that was done by Chef Brownell, and each workshop focused on a different spice or food that they hadn't experienced before, or had, but we taught them how to incorporate these into new ways of presenting it, and also presenting it to the family. So that turned out to be a bit of a challenge. I had some videos of this, but they don't come up. So this required a lot of motivational interviewing. At the end of each workshop, we asked women to stretch. What herb or spice have you heard about that you've never used before? And do you think you can put that into your lifestyle over the next 30 days? So we emphasized adherence to a personal intervention in the workshop goals. We tracked all encounters. There were phone calls as motivational follow-ups. Dr. Ramirez's group is absolutely renowned for doing this type of thing. The control participants, the people in the control arm, were just asked to read the literature that they got, and if they had any questions to call, but they were not called to motivate them. So that was the difference between the 2 arms. So if you were in the intervention, you got a monthly newsletter that was highly personalized. We talked about the tip of the month. We asked them to restate their intention to make changes. We looked at their progress in terms of making those changes. We also analyzed their diet from beginning to end and how that may have changed over the time. And then, because they were in the intervention arm, they got anti-inflammatory recipes that the other arm did not. So our first inclination that something was going on were the people in the intervention arm saying, I have a friend who's been put into the other arm. Can I share recipes with them? And the answer was, we can't. And that told us that there was crosstalk between them. Then the women in the workshop started to bond and develop their own email contact list and develop their own recipes. And they would do things like, this is the first time I put ginger into my diet and recipes, and my husband doesn't like ginger, so when he's out of the house, I put ginger in tonight's meal. And so women would actually change the way they cooked for their whole family, or the other spouse would. And that was great, and really showed us there was something going on. At the end of 6 months, we started to see things from the intervention arm that we did not see in the control arm. Women reported weight loss. This was not a weight loss trial. They reported going off medicine, going off statins, and getting, hey, what's going on with you from your physician? So all those things pointed to some promise. So serum markers were measured at baseline 6 months and 12 months, and I'll just go over the villains here, and they're in red. So if you ever get these drawn on a patient, you don't want to see elevated interleukin-6. That is the guy that stimulates a lot of chronic inflammation. I won't go into the importance of it, but to tumors, if you have a lot of IL-6 on board, it promotes metastasis. TNF-alpha is something that we don't like to see elevated in patients. It increases the CRP marker and a prominent factor in sustaining chronic inflammation. So I lied to you when I started off on this talk saying that we don't have really good markers. We have some that are being evaluated, and it looks like they're associated with chronic inflammation. Interleukin-3 is another one. IL-10 is different, and you would think all these interleukins stimulate inflammation. Well, there's one that puts the brake on it, and it's called IL-10. It actually can inhibit the expression of these other markers. So if you had a perfect trial, if everybody performed like a mouse or a rat, you would say, we might want to see IL-10 increase in a clinical trial during an intervention. Okay, so quality of life measures were put into the patients. So we looked at all these things, the general quality of life, chronic, we measured depression, we measured stress, we measured physical activity, and of course all the anthropometrics that you would want to see in a particular trial. Okay, so let's get to the main point, the trial results. We had a really good randomization, as you can expect. Half of our patients were US Latino, and half were Anglo, with a mixture of other patients. So that split out between the intervention group IG and control group. For the most part, the women participating in this study were not exceptionally poor. They were doing okay. That stratified between control and intervention. About half the women were employed full-time, which made it difficult for us and them to maintain all the workshops. If they couldn't come to a workshop, if you were in the intervention group, we actually gave them CDs of the workshops and how they were conducted. Across the board, there was really no difference between quality of life, between measures of depression, measures of stress, and physical activity. So we had a pretty good randomization. So, results. At first pass, this might look to you like nothing's happened. They're called violin plots. And if you look at the baseline of the intervention group compared to the 6-month value that I can report today, body shape changed. And we necessarily did not have across the board a lot of weight loss. We didn't expect that. But there was a redistribution in the breast cancer survivors who were on the anti-inflammatory diet, so more a protective profile, so getting weight from the upper part distributed more to the lower part of the body. So that's kind of interesting, and we don't know what that means at this point, but in general, you might think that that's a healthier profile. The adipostromal cells, and this is purely a research marker, suggesting that if these fat cells get into the blood, they can lodge somewhere and release estrogen that can promote local recurrence of tumors. It's all purely a research strategy at this point. They're much higher in circulation in obese women than non-obese women. So there's the potential for the body to be delivering these little estrogen bombs to wherever there might be incipient or recurrent breast cancers. So we had no idea whether this marker might be influenced, and just to show you the results of body mass index, weight, generally the same in both groups, but the adipostromal cells were entirely equal. So this intervention did not actually, as a group, as an aggregate, change the level of circulating adipose cells in the blood. What we did find out was a surprise. So we had hoped that the primary marker was CRP and that would be decreased by the anti-inflammatory diet. Now think ahead to your transplant patients. So our patients here, the median CRP, you can see they're 3.0, higher than 3.0. So like the literature says, these are chronically inflamed women, the breast cancer survivors. They're at the highest risk for recurrence and other diseases, as I imagine your transplant patients would be as well. Surprisingly, CRP did not change over 6 months compared to the control, but what did change was circulating TNF-alpha, interleukin-3, interleukin-6. Those are the hot button interleukins for sustaining chronic inflammation. So this dietary, anti-inflammatory sourced culinary intervention did depress chronic inflammation in our on-study interventional patients. Interleukin-8 did not budge, and surprisingly to us, the anti-inflammatory interleukin actually decreased. So a mixed bag here, and we have to think about this as we go into the long-term analysis. So let me kind of finish up. What are the implications of this kind of study? Well, you know, any researcher will say, obviously, more research needs to be done. We don't know how much of these herbs and spices that are anti-inflammatory to give to our patients or how much to recommend. We can recommend that they don't go out and buy curcumin pills or green tea tablets, because the closer you get to a true NSAID in terms of its concentration, you're going to kick in all the side effects as well. If you stay in the culinary zone, in the diet zone, you should have an effect on the body without the consequences. So looking ahead, if we had to do another study, we would want to determine the dose and duration of these interventional food items. We counseled the women to make changes every day, expose themselves to the anti-inflammatory cuisine every day. We didn't tell them how much. We don't know. So beyond breast cancer survivors, I did grand rounds last week at Brooks Army Medical Center. They're intensely interested in looking at this type of intervention in their colon and breast and lung cancer survivors. They're interested in reducing the risk of recurrences and all-cause and specific cancer mortality. Here's an interesting thing. If your patients come in to your clinics, if they have an elevated CRP, the data says they're going to be in hospital longer than a person with low CRP. So just that process of chronic inflammation brings something to the table that will cause your patients to extend their hospitalization. We don't know why. Obviously, we need longer studies and larger numbers. So in the context of the transplant survivor, what we've learned from our study is our women in the intervention arm, they really got religion. They were excited. They were tremendously excited by the fact that what scares them is from the time they leave the doc's hands, you're medically cured, radiation, chemotherapy, surgery, and you're clear of cancer. There's a window in which they see their doc again. And what they really want to do is be involved in intervention that will better their health. They told us that over and over again, and I imagine your transplant patients might do as well. So one of the things we might imagine, and I've talked to Dr. Pourdat about this, is to create an anti-inflammatory discharge plan. If we could actually put this into place where patients can take advantage of all this biology and medicine that's going on and be engaged in bettering their health. So we might be able to fill that gap from the time they are medically stable to manage follow-up visits with an active intervention. There could be other health benefits of an anti-inflammatory intervention after the transplant experience, and might, in time, reduce the risk for certain cancers and potentially benefit reduction in heart attacks. So that's our team. Dr. Ramirez, we had behaviorists on board, exercise people, basic researchers, and a cast of a lot of people. This was a lot of work. We did it on a $200,000 budget, which means everybody contributed their effort to this. And I think we had as much passion going in as we thought the patients might. Then they blew our doors off with their passion. So we're being hammered right now about what can we do going forward. We've enjoyed doing this. We had to even build a San Antonio source list for most of the patients. They didn't know where you could buy these spices or even what they look like. So The last thing to leave you with is that each workshop was a presentation by myself, cooking demonstration by the chef, and then questions and answers. We quickly learned that we did not put in enough time for questions and answers, that they would bring things in from the internet and, you know, what do you think about this? And so it was a great opportunity. With that, I'll be quiet and take any questions. Thank you.